Good evening and welcome again to Montgomery Heart Wellness. And we have an interesting show tonight. I'm going to talk to you about statin drugs. Frequently, patients come to my office and they're on statin drugs. They ask me what I think about them. Frequently, have patients who come in who've been prescribed statin drugs by the doctors and have questions about should I take it? I've heard bad things, etc. So my goal tonight is to give you a brief overview on statin drugs. Are they good? Are they bad? Give you a little bit of insight so you can make objective decisions in terms of whether you should take a statin or is it beneficial to you. So I want to, first of all say that my comments will be general. They will be, not really medical advice. So just, take that with a grain of salt. So first and foremost, let's get into statin drugs. Are they good or are they bad? And of course, as I said, this isn't medical advice. Consult your physician about any health issue and any medical advice, including statin drugs. However, I want to give you an overview. And my goal, as always, with these videos, particularly with ones of this type, is to give you some insight to help you become your own expert in your healthcare decisions. So why does someone take any medication? Well, first and foremost, one reason would be to eliminate or alleviate immediate pain or discomfort. You may have, a sore ankle or an injury. You may take an NSAID. You may want to alleviate or eliminate immediate injury or death. We give steroids sometimes if someone's having an allergic reaction, or thrombolytic drugs if you're having a heart attack, especially in the old days. What about the risk of long-term injury? Certain medications are used to prevent heart attacks or prevent stroke, so there may be a potential long-term injury. How about long-term function? Some drugs are taken for that. Hormone replacement drugs. If you have thyroid disease, you've had your thyroid gland removed, then you would also be taking something for long-term thyroid function. And how about long-term quality of life? And of course, long-term survival. Some drugs are thought to or prescribed for the sake of improving your potential survival. So what about the statin potentials? Which one of these things that statins are thought to or are credited with providing some benefit? They don't really alleviate immediate pain or discomfort. You don't take a statin because you're hurting anywhere. Immediate injury or death, no. Could they prevent long-term injury? It's thought that they could. There's some data showing that they can prevent a long-term heart attack, but how about long-term function? Not really. How about long-term quality of life? It's not thought to contribute to that necessarily. But could it enhance long-term survival? That's some data that suggests that it does that. And we're going to look at some of that in a brief way today. So that's where you are with statin drugs. How do they work? What's the mechanism of action? We create medications based on learning certain aspects of how the body works. So in the case of statin drugs, and this came out the publication came out around the time I was a freshman and sophomore in medical school. They understood this pathway, this 3-hydroxy 3-methylglutaryl-CoA molecule was converted to mevalonic acid, kind of a mouthful. And this enzyme, the HMG-CoA reductase enzyme, was thought to be key in this rate-limiting step here. And so when they found the enzyme, they created a molecule, a chemical, that could reduce the function or eliminate the function of this enzyme. So therefore, it reduced the progression of this biochemical enzyme pathway to cholesterol formulation. And so you can reduce cholesterol. If you look at the package insert, now I pulled the one for atorvastatin. There's lots of overlap with the different statin drugs. That basically indicated for reducing heart attack and stroke revascularization procedures and angina or chest pain, as you know it. In individuals with multiple risk factors for heart disease, they are thought to reduce heart attack and stroke with people with diabetes and multiple risk factors. and also thought to reduce non-fatal heart attack and fatal stroke, non-fatal stroke, and revascularization procedures and hospitalization for heart failure and chest pain in people with known coronary heart disease. And notice how they isolate certain things. In this group, it's non-fatal heart attack and non-fatal stroke. So you say, well, what about fatal heart attack and fatal stroke? Apparently, the data didn't show that. And of course, it reduces total cholesterol, LDL cholesterol, which we know as the bad cholesterol, to atherogenic particle ApoB and triglyceride levels. They talk about increasing HDL. I don't think they do that so well. And this is in various conditions, whether it's heterozygous familial hypercholesterolemia, homozygous familial hypertriglyceridemia, etc. So the indication primarily of reducing LDL cholesterol and the like. How about the adverse reactions? Now, many of you out there who have taken statin drugs or who have loved ones who's taken statin drugs probably know this better than I do, obviously. Here's the adverse reactions taken from the package insert. These are clinical adverse reactions that occurred greater than or equal to 2% in patients treated with any dose of the statin that had a greater incidence than the placebo group. So quite a long list: nausea, dyspepsia, pain in extremities, diarrhea, nasopharyngitis, a whole list of things that could happen. Now, this whole concept of absolute risk versus relative risk, we're going to talk about this a little bit today. I was going to go into some definitions, but I felt I would simplify this talk. I didn't want to get into some epidemiology. The essence is we look at things based on the reduction of risk of an event happening. There's this concept of absolute risk versus relative risk. The relative risk, you may compare the risk of two different populations at risk. Absolute risk, you look at the risk of a total population of people. The reduction in these two groups can be different. And so typically you want to look at absolute risk when you're looking at a medication that is being used over a long period of time. The other aspects of medication use that need to be considered that people don't think about, one, the adverse effects of the drug may contribute to increased death over time. So we often think about the benefits of a drug, but the side effects of a drug may be cumulative over time. And so there may be a point where initially the side effects of a drug are very low to where the benefits outweigh the risk of the drug. But then if you're on that drug for a long period of time, those adverse effects start to overcome the benefits, and then it becomes a negative process. We'll talk about that a little bit more later. There are other biological factors that are not controlled by the drug may get worse over time. So like, for instance, lowering cholesterol may be beneficial maybe early on in someone's life, but there may be other aspects of their biology and physiology that may worsen over time that may increase their risk for heart attack, that to a point where lowering cholesterol is less important. Absolute versus relative risk reduction can diminish over time. So you may have a very high absolute reduction of risk reduction and a very high relative risk reduction. But over time, due to some of these other real-world factors, those risk reductions can be diminished over time. And in fact, these drugs have not have a net increase in risk over time due to these factors. So in other words, the adverse effects of a drug can become so great over time, then you may have a net adverse effect. Now, one well-known drug is a drug called milrinone. And if you've seen some of our talks, you may have heard us talk about it in clinical rounds. But milrinone is a drug that we use in the hospital in people who are in acute decompensated heart failure. And that drug is used in intravenous form. It dilates blood vessels and it forces the heart to beat stronger. In a very short period of time, that drug can be very, very helpful in patients. I've used it a lot for the purpose of turning patients around acutely with heart failure to get them stable, certainly out of the ICU. And so in that short duration of time, maybe 24, 48 hours, that's a wonderful drug, maybe 72 hours in some patients. However, when they did a study looking at this drug in oral form, And they looked at it over months, and 6 months, in fact, this drug had a net adverse effect. So it killed more people than placebo. So the same drug that in a short period of time that could be beneficial, in a long period of time, because of the adverse effects that increase over time, it has a net negative effect. And so this can happen with really any drug. So what about statins? So there was a group of scientists who reviewed a number of statin trials. So we come up with the indication, they do trials, they have thousands of people in the trials, and they looked at the comparison of the relative risk compared to the absolute risk of statin treatment. And they did a systematic review of the data. So they looked at trials from 1987 to 2021. And now the important thing I want to emphasize by these trials, the duration range was from 1.9 years to 6.1 years. Now, this is very important because these trials lasted for anywhere from 2 to 6 years, and the average duration was 4.4 years. So the data we have on statin drugs, on average, roughly 4.4 years. So when you have someone on a drug for 6, 8, 10, 12, 15, 20 years, we don't have data for that. And so some of the points I mentioned earlier, there's adverse effects. What are the adverse effects of statins over 8 years, 10 years, et cetera? We don't know. And so the data doesn't exist there. So what they found, however, when they looked at these drugs, because most of the publications and the indications emphasize relative risk, but when they looked at the absolute risk, the total risk, the risk of all-cause mortality is only 0.8% compared to 9% relative risk. If you look at the risk of a heart attack, myocardial infarction, the absolute risk was only 1.3% compared to 29% relative risk. So when we get the indication of publications and it's presented at our meetings, we're given relative risk. And then, of course, the risk reduction in stroke was only 0.4% compared to 14%. So when you look at the absolute risk, and this again was only an average of 4.4 years. And as I said earlier, this absolute risk reduction, relative risk reduction can diminish over time. So even absolute risk reduction, maybe if you look at it for 5 or 10 years, may actually go down to 0 or negative. And so the conclusion based on this meta-analysis was a conclusive association between absolute reduction in LDL-C cholesterol, total cholesterol levels, LDL cholesterol levels, and individual clinical outcomes was not established. So they couldn't really conclusively say that by lowering bad cholesterol, you can improve clinical outcomes because the absolute risk was so low. So these findings underscore the importance of discussing absolute risk reductions when making informed clinical decisions with individual patients. So they're telling doctors, look, take a look at the absolute risk of these drugs, not just relative risk, because you have someone on the drug for 5, 10 years, that can have an impact. So what are my thoughts? Now again, it's not medical advice. I'm just sharing my thoughts about the drugs and how I think about it when I'm seeing patients. First of all, what are my concerns? Well, one, we don't have any long-term data on these drugs. By that, I mean data greater than 6 years. So as I pointed out earlier, these trials, most of these big trials were on average 4.4 years. The long-term adverse effects may outweigh the benefits. So, the adverse effects of the drug 5, 10, 15 years ago out from using a drug is not measured in these trials that are only 4.4 years long. The other things are unknown effects of drug-drug interaction with new drugs coming on the market. When we did these trials for statin drugs, for example, the new weight loss drugs, GLP-1 agonists, were not on the market. So we don't have data in a population of people taking new drugs that are on the market. And so there are new drugs coming out all the time, and many patients are on 5, 6, 10, 15 drugs, and the drug-drug interactions are unknown. And then there's specific potential adverse effects with statin drugs, particularly liver dysfunction, potential brain dysfunction, potential muscle dysfunction, and other general metabolic problems that you can have with these drugs. So My opinion with statin drugs, generally speaking, is I'm not a big fan of statin drugs. I try to work with patients to improve their overall health, improve the overall metabolic function of their body. I also talk to patients about nutrition, diet. Now, that doesn't mean I never prescribe a statin drug or refill it. There's certain cases that I do prescribe statin drugs. But I, like my colleagues, don't just automatically prescribe a statin drug for someone who has a risk factor. Oh, if you're diabetic, here's a statin. Oh, you had a heart attack, here's a statin, et cetera, et cetera. I'll think about the patient's health in totality, and then I will make a decision on whether to use a statin drug or not. But I don't just jump on board and just prescribe a statin drug. Now, uh, that doesn't mean your doctor is wrong for prescribing a statin drug. This isn't medical advice. But I give this insight and share my thinking with you so that you can be better informed. You can research the information I shared with you, but give some thought to any and all medications that you prescribe, and statin in particular. So I hope this was very helpful to you. And please leave your questions and comments in the comment section. I always make use of this information. I've done shows based on questions and comments made and insightful commentary. So that's always very helpful. And of course, if you're new to the channel, please subscribe. And if you're new or a veteran, please like and share this. Many people can get some information from this. So until next time, you guys take care. Look forward to seeing you in the next video.